Hello, ladies and gentlemen. We are going to talk about the arterial system today. Okay, you know now everything about the heart, and we can start from the heart, from the right ventricle, and the main vessel emerging from the right ventricle is called pulmonary trunk, truncus pulmonalis, which is quite short and thick vessel. And it has no side branches, it just terminates by bifurcation in a right angle into two pulmonary arteries, and then the pulmonary arteries enter the pulmonary hilum and branch into lobar and segmental and subsegmental arteries and so on. Inside the pulmonary trunk, there are some interesting structures like sinus. There's three sinuses, right, left, and anterior, which are located above the semilunar valves. Yeah, so they are located above. Above the level of the sinuses, there's a small supravalvular crest, and then it continues and ends as a bifurcation into two pulmonary arteries. From the top or from the beginning of the left pulmonary artery, there's a communication in fetal period which is called Bottal's duct, ductus arteriosus Bottali. After birth, it is closed by reflex, and the blood does not flow anymore into aorta and then into placenta, but continues into lungs to be oxygenated. And it changes into a ligament. So it's called ligamentum arteriosum of Bottalo. Yeah? So the pulmonary trunk and its branches serves for functional lung circulation. Yeah? We know that the nutritive lung circulation is assured by bronchial arteries, which are branches of arch of aorta and ascending aorta. What is pulmonary capillary wedge pressure? If you put in a catheter, which comes usually from a femoral vein, and then via inferior caval vein into right atrium and right ventricle, you get here. And where you stop with the catheter and you could not go farther, you can measure the pressure there. Yeah, as a wedge, you get into the lumen. You stop. You could not go farther. So that's why it's called capillary wedge pressure. And this is the pressure you can directly measure. What is pulmonary embolia? I think you all know. If we have any thrombus inside the veins of lower limb or pelvis, this thrombus can detach and can travel via the venous system and get into the right atrium, right ventricle, and then can be entrapped somewhere in the branching of the arterial tree and can cause pulmonary embolia. Yeah, and here, of course, on the figure we can nicely see the pulmonary trunk. Yeah. Okay, so that's all for pulmonary trunk, and here you can see a very, very clinically important situation, which is quite rare, and it's left coronary artery. Yeah, you can see how it spreads here as the anterior interventricular branch, and here as the circumflex branch, and you can see it's a branch from pulmonary trunk. And the right one is branched from aorta as usual, but here you can see how the left one is branched from the pulmonary trunk. So what is then the problem here in this patient? It's of course hypoxia of the left ventricle, and then the left ventricle is hypertrophied and cannot pump, and it can terminate as a heart failure. Yeah, so this is very rare, but clinically very important situation. So now we can finally Start with aorta, and here what we can see is the 3D angiography reconstruction, and you can nicely see ascending aorta, aortic arch, and then descending aorta. And the descending aorta can be divided into the thoracic and the abdominal part. Yeah. Okay, from ascending aorta, we can nicely see these enlargements, which we call sinuses. And the whole area here we call a bulb. Yeah, this is the aortic bulb. And from the sinuses, we can nicely see the right and left coronary artery. Yeah. Then we can see the aortic arch, and from aortic arch, 3 main branches. So brachiocephalic trunk, truncus brachiocephalicus, which then divides into subclavian artery, and this is the right one, and common carotid, and the right one. On the left side, these two arteries are separate, so we can see left subclavian and left common carotid. Moreover, you can see the vertebral here, the first branch of the subclavian, which ascends, and internal thoracic, yeah, as the first branch which descends. Nicely. If you have any questions, of course, you can directly ask.
Yes, Dr. Karlik, on the I don't remember which imaging method it was, but on the heart picture, you had ACS, pulmonary trunk. Can you tell what ACS stands for?
Yeah, it's arteria coronaria sinistra, so the left coronary artery. Yeah.
Okay, thank you.
So here in this 3D reconstruction, we just add the ribs, so it is not then so easy to see the branching, but you can nicely compare the branching to the bony structures which we have there. Yeah. So about the ascending aorta, you should know that we have the bulb, and the bulb contains 3 sinuses, and we call the sinuses of Valsalva, which is much used in clinics, right, left, and anterior. And right and left, posterior, there's a mistake. Posterior, of course, because anterior is in the pulmonary trunk, posterior is in the aorta, ascending aorta. And the right and left, they give the origin to coronary arteries, and the posterior is so-called non-coronary because there is no branch usually. Above, we can find supravalvular crest again, and that's all for ascending aorta. It's a very short and thick vessel, and it together with arch of aorta suffers from aneurysms. If we have an aneurysm, you have to replace it with this prosthesis, and into the prosthesis, of course, you have to add the coronary arteries here. Yeah? During this operation, the blood is perfused via the subclavian artery in this way. Yeah, this is the extracorporeal pumping. Yeah, for aortic arch, we have already talked about the branches, and we know that all mammalia has got a left-sided aortic arch. Yeah? The right-sided is in lower species like birds, but of course there can be an exception that we have a right-sided arch of aorta. We have here a term isthmus. What is isthmus? Isthmus is when we have the heart and aorta, and the 3 main branches. Then isthmus is this part, and this is isthmus of aorta, and it's usually when here is the pulmonary trunk, is the area where the ligamentum arteriosum attaches. Yeah, and it's a bit narrower, but only a bit. The lomera aortica are aortic bodies which serves as baroreceptors and chemoreceptors, yeah, for blood pressure and for the partial pressure of the oxygen. And we are within the superior mediastinum, and we are behind the vessels and in front of trachea and esophagus. So that's for the topography. And of course, there can be many branching variants, as you can see here. These branching variants are important for surgery, and we should know about 3 of them specifically. One is this, which we call arteria lusoria, yeah, or in English it's sometimes called an aberrant right subclavian, usually retroesophageal artery. Yeah. So as you can read here, it's an subclavian artery, the right one, which is not branch of brachiocephalic trunk as it should be usual, but it's branching as the last branch and running behind all of them, and usually behind esophagus. So it can compress esophagus and it can cause dysphagia. Why it's called lusoria? Lusus means in Latin it means a sin of nature. Yeah, so this is like a sin of nature. That's why arteria lusoria or aberrant right subclavian artery. Another variant which we can see is this one. Sorry, different color. When a vertebral artery is not branch of subclavian, yeah, it normally should be a branch of subclavian here or here, but it's a branch from the aortic arch. It's important if you apply a prosthesis, you have to think about the vertebral artery, and you have to put the origin of the vertebral artery somewhere, not to forget it. And then we have an artery which is not drawn here, but it can be present like this, running in front of trachea and can hinder I'm sorry, the tracheotomia, and it's called arteria thyroidea, IMA, which means the lowest thyroid artery, and it supplies the thyroid gland from below. Yeah. So these 3 are clinically important. Even you can see they are quite rare, but they are important and you should know about them. Okay, now let's talk about the branches. The brachiocephalic trunk has got no side branches. It just terminates into subclavian and common carotid. And the common carotid has got no side branches, and it terminates as the internal and external carotid at the level of C4. Yeah. So at the level of C4, we have a bifurcation. The bifurcation is visible here. So because there are no side branches, what is important is where it ascends. It ascends within the carotid sheath together with the vagus nerve in the internal jugular vein. And you find it inside the parapharyngeal space. And if we look at that, we can see 2 triangles. Yeah, here we have the cut omohyoid muscle. So we can find it in omotracheal triangle and then in carotid triangle. And in the carotid triangle, you can palpate it. You can use the ultrasound. If there's a bleeding, we can compress it against an anterior tubercle of the 6th cervical vertebra, which is called Chassaignac's tubercle. Yeah, this is a bit larger than the other ones. We don't know why, but it exists. And at the very end, we find another receptor, which is called carotid body, or in Latin glomus caroticum, which is a chemoreceptor for the partial pressure of the oxygen. Yeah. So you can see no branches, but clinically very relevant, and the topography is not easy. Oh. If you have questions, you just ask, or anytime. Yeah.
Yeah, sorry. On the variations of the aortic arch, you said that one of them can compress the esophagus, causing something I cannot remember.
It can cause dysphagia. Dysphagia are problems with swallowing. Yeah,
Oh.
so swallowing problems. Yeah.
Thank you.
Yeah. So here you can see the level of the carotid body, the glomus caroticum. It's innervated by glossopharyngeal and vagus nerve. Yeah, so that's the carotid body here. And we can nicely see the area of the bifurcation. You can see that the beginning of the internal carotid artery is enlarged. Yeah, and this we call carotid sinus. Yeah, it is necessary not to mix it. So sinus caroticus, or the carotid sinus, that's baroreceptor. Yeah. That's baroreceptor, and we have talked just several seconds ago about the structure which can be found here in between the two carotid arteries, and we call this glomus caroticum, a carotid body, and this is a chemoreceptor. So please do not mix them. Yeah, carotid body is in the bifurcation, and it's chemoreceptor for a level of the oxygen, partial pressure of oxygen in the blood, and carotid sinus is the enlargement of the beginning of internal carotid artery, and it's a baroreceptor for the blood pressure. Yeah, both are innervated by glossopharyngeal and vagus nerve and serves for the reflexes. Okay. So now the bifurcation into the external and internal carotid artery. So what we should know about them. External has got 8 branches, and it supplies what is externally. That means the face, yeah, all the covers of the skull, tongue, oral cavity, pharynx, even meninges. The internal carotid artery has got no branch on the neck, and it supplies what is inside the skull. That means the brain and the eyeball, yeah, and the orbit. Internal and external, the names are derived from what they supply. So internal supplies the internal content of the skull. The external supplies what is externally on the skull. But as for the topography, the internal one is located dorsally and then laterally. So you think it's located more externally on the body. And the external one is located ventrally and medially. So you think it's more internally located. So please pay attention to that the internal one is located dorsolaterally and has no branches, and the external one is located ventromedially and has good branches. So if you look here, you can nicely see the internal one, no branches, yeah, but the position is dorsolateral, and the external, which is ventromedial, and then gives branches and continues here. Yeah, so this is not to be mixed. So here an easy scheme showing us the branches. Now let's talk about them. How to divide them? I think you may know names of all of them. So we have the ventral ones. And think about what you have ventrally. Yeah? Ventrally, you have the thyroid gland, the larynx, we have the tongue, Yeah, and you have the face. So we have the superior thyroid artery, which gives also the laryngeal artery. We have the lingual artery for the tongue, and we have the facial artery for the face. And the facial artery terminates in the angle of the eye as the angular artery. Then we have dorsal arteries and dorsal branches. So what is dorsal? Dorsal is your nape of the neck and the occiput, yeah, and the ear. So dorsally, you have the occipital artery, and then we have the posterior auricular artery, yeah, supplying the ear. And medially, we have one branch. Medially, we have ascending pharyngeal artery, yeah. Ascending pharyngeal artery, as the pharynx is the medial organ. It's unpaired, and it's not ventrally. It's quite dorsally, but still medially to the vessels. So ascending pharyngeal artery. And then we have the final branches, which we call terminal. And the terminal are maxillary branches supplying the depth of the face, yeah, as far as the pterygopalatine fossa, and terminating as the infraorbital artery, so below the eye here, and the superficial temporal artery, which supplies the covers of the skull. Yeah. So this is the division into the main arteries. Do we have any artery lateral? Laterally, yes. Laterally, we can have a small sternocleidomastoid artery supplying the sternocleidomastoid muscle. That's the only branch which is located laterally. So that's the main branching. And now let's go to talk about details. So what about topography? So the bifurcation is located at the level of C4, so within the carotid triangle. And now we are not anymore in the parapharyngeal space, but we know that the parapharyngeal space is divided by styloid septum into two spaces, pre and retrostyloid. So the external carotid artery runs into pre-styloid space. On the contrary, the internal carotid artery into the retrostyloid space. So we are in the pre-styloid space, and it is on the neck. It's covered by sternocleidomastoid muscle. Yeah, it is crossed by hypoglossal nerve, and it gets inside the parotid gland. Yeah, so within the parotid gland. So here in this area, we are inside parotid gland. Okay, so you can see it here, carotid triangle, and sternocleidomastoid muscle, and parotid gland. Yeah, so we are getting here into the parotid gland. Now let's talk about the branches. So the first branch is superior thyroid artery. Superior thyroid artery descends down inside the carotid triangle and descends as low as the thyroid gland. It supplies the thyroid gland together with the inferior thyroid artery, which is branched off from subclavian. It gives some branches on the way. You can nicely see here superior laryngeal artery. Yeah, superior laryngeal artery is here, which enters the larynx together with the superior branch with the superior laryngeal nerve, the internal branch here. Then we have the cricothyroid branch. Yeah. The infrahyoid branch is here. The cricothyroid branch is not visible here. And then we have finally three branches from the thyroid gland, yeah? Anterior, posterior, and lateral, which is then important for the operations. So it's important it descends with the superior laryngeal nerve. And we can see it here. It supplies the upper part not half, but the upper part of the thyroid gland. So that's all what we should know for the superior thyroid artery. The second branch is the lingual artery. Yeah, so here we can see the superior thyroid with the superior laryngeal, and then we have the lingual. So the lingual is visible only partially, and then it's hidden by muscles. Yeah, we can see here the hyoglossus, and it's hidden behind the hyoglossus muscle. So it gives some branches. We may know, or we can see here, the infrahyoid branch was branched from superior thyroid artery. The suprahyoid branch is branched from lingual. And then it supplies the tongue with three branches: the dorsal, sublingual, and deep. You can see it nicely here. Yeah. The lingual artery behind the hyoglossus muscle, and giving the dorsal branches, yeah, to the dorsum of the tongue, giving the deep branches inside, and giving the sublingual one, which supplies the floor of the mouth, of the oral cavity, together with the sublingual and submandibular gland. So this is the branching. And now a bit of topography. You can see that it goes here close to a greater horn of the hyoid bone. You can easily palpate, yeah, if you find larynx, you go up, you palpate hyoid bone, and on the lateral side you can palpate it. Just behind that is the lingual artery. It is not so well palpable, but we come here to this special structure. I think I have it here as well. We can call this Backlards Angle. Yeah, Backlards Angle, he was a French. And the angle is between the greater horn of hyoid bone and here the posterior belly of digastric and stylohyoid muscle. And this is the Backlards Angle. And then it continues further, and with different color we can show another angle, and it's not only angle, it's a triangle, and it's a triangle of the lingual artery. And the triangle of the lingual artery is bordered by hypoglossal nerve, which is here. Then it's bordered by posterior belly of digastric, and it is usually bordered by mylohyoid. Sometimes you can see there's a little bit of the border of the anterior digastric, or anterior belly of digastric, yeah, but usually the mylohyoid, the posterior belly of digastric, and hypoglossal nerve. So in these two spaces, it can be reachable. Why? The triangle is called Triangle of Pirogov. Pirogov was a Russian anatomist and surgeon, and during a war between Turkey and Russia in 1860s, he saved many lives of soldiers who were hit by grenades into the face, that they just opened the neck and ligate the lingual artery. Of course, you can use it in military surgery, but we use it in resection of tumors of the tongue. Yeah. So how to find lingual artery? Easily, you find the hyoid bone, you find the muscles. You have to pay attention to the nerve, and then you can easily ligate the artery. The artery is of course hidden here by the hyoglossus muscle, as I showed before. Yeah. So it is not easy to see the artery directly, but you have to go through the fibers of the muscle here. So please remember these two topographical sites. First, the angle of Backlard, and then the triangle of Pirogov. As for the artery, you can see that it passes under the hypoglossal nerve, under the two suprahyoid muscles innervated by facial nerve, the posterior belly of digastric and stylohyoid, and of course under the hyoglossus muscle. And then it gets inside the tongue itself, and this we call a paralingual canal. So a quite short artery and very much information for that. Okay, we can go on for facial artery. Facial artery has got much more branches, but it's easier to imagine. Yeah, you can see it nicely running obliquely across the face. You can see that it's tortuous, sinuous, yeah. And it's because we move our face. If I do all these movements, we need to adjust the artery to these. That's why it's tortuous. Do you know any other tortuous artery in the human body we have? We have another two you should know.
Uterine.
Perfect. Uterine, because uterus can be enlarged 10 times. And
Helicin.
no, splenic. Splenic, as the spleen is a bit movable, yeah, and the splenic is also tortuous. So this is the facial artery. It goes across the across the body of the mandible here, so you can palpate it. How? You find your masseter muscle, and when you find the anterior margin, here you can feel the pulse of facial artery, and you can palpate. So this part is nicely visible, and the branches are also nicely visible and not making a problem. So we have the inferior labial artery here and the superior labial artery here, which makes arches within the lips. We have the lateral nasal branch, which is not well shown in this figure, somewhere here. And then we have the angular one, which is this one, and terminates here at the medial angle of the eye. So these four branches are nicely visible. The last branch here below is the supplemental. Yeah, this is the supplemental artery. And then what about the other branches? These we cannot see so easily. And these are glandular branches from submandibular gland, yeah, and I will show you in a minute the relationship. And then tonsillar branch for palatine tonsil and ascending palatine artery. These are not so easily visible on this figure. The ascending palatine artery is here. Yeah, this small one. So for the facial artery, I'll try to find a figure nicely here. Yeah, here you can see the submandibular gland. This is the lingual, and now I draw the facial. The facial is here, running behind posterior biliary digastric and stylohyoid, inside the gland or even behind the gland, and then here across the body of mandible. This is the submental artery, yeah. And the ascending palatine we cannot see because it's branching behind these muscles. Okay, now let's talk about the topography. So first, where we have the gland, it's inside the submandibular triangle. Sometimes it originates together with the lingual artery. So we can have a variant which is called linguofacial trunk. Yeah? Then, as we said, it passes under two muscles, and it passes under, or it pierces, the submandibular gland. We can palpate it here on the caudal margin of the mandible, ventral to anterior margin of masseter, and then it continues in the face. So, do you have questions about these? If not, we can continue into the occipital artery. The occipital artery branch is still in the neck, so below the level of the muscle. So here we have the level of the posterior biliary digastric. So the occipital artery branch is below and the posterior auricular above, so already in the head. You may know that there's a shallow groove of occipital artery on the behind the mastoid process of the petrous part of the temporal bone, yeah, just close to the mastoid notch for digastric muscle for the posterior belly. So this is the groove here, and it gives some branches. Some of them are important, like meningeal branch, which goes into mastoid foramen. Yeah, this is mastoid foramen, and it gives here a meningeal branch. And then there are many smaller branches. Sternocleidomastoid to supply the muscle, the mastoid ramus supply the mastoid process, the auricular branch supplying the posterior aspect of the auricle, occipital branches supplying the external surface of the occipital bone, and descending branch supplying the deep back muscles in the suboccipital area. Yeah, so there are some smaller branches. That's for the occipital one, and now it's friend a bit above, and that's the posterior auricular. Yeah, so its origin is already cranial to the posterior belly of the digastric, and it gives some smaller branches like auricular branch again for the posterior aspect of the auricle, occipital branch which heads toward the occipital bone. Then it gives branches to parotid gland, as we are here already in the area of the parotid gland, so to the posterior aspect of the parotid gland. But then mainly it gives an artery inside the skull, and it goes into the stylomastoid foramen. So it enters the third mastoid segment of the facial canal, and it supplies the mastoid cells inside the mastoid process, but it supplies also the tympanic cavity as the posterior tympanic artery. It runs together with the chorda tympani, through the posterior or mastoid wall. And it also goes into pyramidal eminence to supply the stapedius muscle, so it gives the stapedial branch. These are smaller ones, but they are important for the blood supply of the ear area. Yeah. So this is the posterior auricular artery. Now let's go to talk about the medial branch, the ascending pharyngeal. Yeah, you can see that it's quite short here. It's cut, but it ascends as far as the skull base here. It supplies a majority of the pharynx by smaller pharyngeal branches, but when it comes to the skull base, it gets inside and gives posterior meningeal artery. Do you know by which opening it enters the skull? You should know it from the skull. It's foramen jugulare, the jugular foramen, and the inferior tympanic artery. It goes via tympanic canalicus, which is in fossula petrosa. You may remember that from the skull as well. So you can see that this is the second artery supplying the tympanic cavity, this time from below, through the jugular wall. We find it in the erythrostyloid space. So please remember that the external carotid artery is in pre-styloid space. And in erythrostyloid space, we find the internal carotid artery together with the ascending pharyngeal, which is branched from the external carotid. So don't forget about that. So this is the ascending pharyngeal artery. And we can see here nicely, this is the transverse section here, through the level of C2 approximately. And this is the styloid septum. Yeah, this is sternocleidomastoid, posterior belly of digastric, stylohyoid, styloglossus, and stylopharyngeus muscle. And we can see the external carotid artery, parotid gland, and the retromandibular vein. And here you can see the parotid duct opening above the second upper molar. Yeah. This is mandible with the masseter and medial pterygoid. So this was external carotid artery. This is internal carotid artery, jugular vein. And this is ascending pharyngeal artery. This is ascending palatine, branch of facial, and palatine tonsil. So ascending pharyngeal in retropharyngeal space. And you can see if we see these smaller branches that it supplies not only pharynx and middle ear cavity, but it also gives branches up to inside the cranial cavity, so it gives also branches for clivus and so on. Yeah, but it is not necessary to know all these branches. And now finally the terminal branches. The easier one is superficial temporal. You can see it how it descends here up. Here the auricle is flipped, but if you see the auricle in the external acoustic meatus, you can palpate here the superficial temporal artery. And if not here, on your forehead, you can sometimes find and palpate its branch. Yeah? The branch is here cut, but we call it the frontal branch. So this is what you can even see, the tortuous course here. I don't know, I think I do not have it, but some people have it. But you can palpate, that's the frontal branch and the parietal branch. The artery itself, as it supplies the skin here, is used, and the skin is used as a cutaneous flap, just to move it somewhere on the face if you need. Yeah. So in reconstructive surgery, we use a skin flap on the superior superficial temporal artery. So please remember, we have it here together with the auriculotemporal nerve. This is the auriculotemporal nerve. So which other branches we have here? So we have talked about the final ones, the frontal and parietal. Yeah, which are these? The parietal and the frontal. And now we can see that there are other branches. So the largest is transverse facial artery. Transverse facial artery is this one. Yeah, transverse facial. It goes transversally across the masseter muscle towards the zygomatic bone. Yeah, and it runs not far from parotid duct. Then we have the zygomatic orbital, which is smaller. And zygomatic orbital is this one. It's the zygomatic orbital. And it runs along the zygomatic arch towards the here towards the lateral angle of the eye. Then we have the deep temporal. Deep temporal is not visible here. I'm sorry, not deep temporal, middle temporal. I'm sorry, middle temporal. Middle temporal is not visible here as it goes below the temporalis muscle. And you may know that we have here a groove on the squamous part of petrosal bone. We have a groove, shallow groove, which is called the groove of middle temporal artery. Yeah. So we have the middle temporal artery. And then there are smaller branches for the auricle, anterior auricular branches, and a parotid branch for the parotid gland. So this is the superficial temporal artery. And as I said, it's palpable and compressible ventral to the auricle. It serves as a pedicle for cutaneous and musculocutaneous flap. And if you have a patient who has got here in this area a painful red bend on the skin, the patient can suffer from temporal arteritis, yeah, inflammation of the artery. It is quite rare. It is inflammatory, non-infectious rheumatic disease, or arteritis. Yeah, It is you can find it in different arteries, but quite specific is to the superficial temporal artery. Okay. So that's for the clinics. And now the most complicated maxillary artery. You would say it's a bit of horror, this artery, but if you know the skull and the openings and the contents, it is not a problem. Yeah, it's just necessary to recollect. So, as it's branched from the external carotid artery, find it inside the pre-styloid space. It branches inside the parotid gland. Yeah? And anatomically, we can see it passes ventrally to sphenomandibular ligament. This is just for orientation. So it gets ventrally into the infratemporal fossa. We know that infratemporal fossa is filled with pterygoid muscles and the insertion of temporalis muscle. So the maxillary artery passes here. And it can pass either ventrally or dorsally to the lateral pterygoid muscle. So if you operate in this fossa, there should not be a surprise for you if you do not see the artery directly when it's hidden behind the muscle. Yeah, so it's nearly 50-50 that the artery is either ventral or dorsal to lateral pterygoid muscle, which we can see here, the lateral pterygoid with two heads. Then it passes into the pterygopalatine fossa, and how it gets into through the pterygomaxillary fissure between the pterygoid process and the maxillary tuberosity. Yeah? So it gives 13 branches. We distinguish 3 segments or parts based where it travels. The first is behind the neck of mandible. Yeah. The second is inside the pterygopalatine fossa. So we can say the first is in a pre-styloid space, second in infratemporal fossa, and the third, which is totally hidden in the skull, is within the pterygopalatine fossa. Yeah. So these are 3 parts. And we can see the branches here. Let's talk about the branches. So behind the neck of the mandible, we have the mandibular part, and we have 4 branches. First, there are 2 small, and deep auricular. Yeah, deep auricular, the first one here, which supplies, just stay here with the pen. It supplies the anterior aspect of the auricle. Yeah, clinically not so important. The second branch is the anterior tympanic artery. You already know this artery as it supplies the tympanic artery from ventrally, so it enters it via the carotid wall together with chorda tympani through petrotympanic fissure. Yeah? So this is the third artery which supplies the tympanic cavity. So that's an interesting one. And now the larger ones, inferior alveolar, which you can see here, together with the inferior alveolar nerve running inside the foramen mandibular and canalis mandibular. And it supplies all the lower teeth. Before it gets inside the canal, it gives here this branch, which is called mylohyoid branch, and it runs with the mylohyoid nerve to supply what is here, the mylohyoid muscle and the anterior belly of digastric. So you can see it as well here down. Yeah, so there's the mylohyoid, and this is the inferior alveolar. And of course, the inferior alveolar then appears superficially here as the mental artery, and it's just below the angle of the mouth here, together with the mental nerve branch of the mandibular nerve. And the last branch, clinically the most important, is the middle meningeal, which is hidden here. It goes into foramen spinosum together with the meningeal branch of mandibular nerve, and then it ramifies inside the skull. Yeah, where is the groove for it? And it gives frontal and parietal branch, The frontal comes as far as to the orbit and gets into the orbit and anastomosis with the lacrimal artery. Yeah. We will talk about the lacrimal artery in some minutes. So there's an anastomosis with the lacrimal artery. The posterior, the parietal branch, gives two branches. One is superior tympanic, so it's the fourth tympanic, which comes from above, together with the lesser petrosal nerve, and supplies the tegmental wall. And next to it is a petrous branch. And as you can see, the superior tympanic and the petrous branch, they enter the canals which are lying on the superior surface of the petrous part of temporal bone, where we have two petrosal nerves, the greater medially and the lesser laterally. And there are two branches entering each of these canals. Yeah? So that's the middle meningeal artery. But clinically, the middle meningeal artery is important from different point of view. Yeah, we can see it here. I'll just circle it. See it here with the veins. Then it branches into the frontal and parietal branch. Here you can see the two branches which runs with the petrosal nerves. So this is the lateral one, which is superior tympanic artery. And then we have the medial one, which is the petrous branch. Yep. And of course, there will be the branch into the orbit. But what is important when we get a hit into the skull, what can happen is that the artery can be torn and there starts a bleeding, which we call epidural bleeding, because the bleeding gets here between the bone and the dura mater where the artery is, and it enlarges and forms such a lentiform shape bleeding. This bleeding compresses the brain and it can cause a loss of consciousness and even death. So what you have to do, even the old Egyptians have done it, you just drill a hole with, and we call it trepanation, and you remove the blood. Yeah. So remember, middle meningeal artery can cause epidural bleeding. How the epidural bleeding really looks like, we can see here. This is the lentiform shape of the bleeding. Yes. We have more kinds of the bleedings, not only this one, which is the epidural, but we can have a subdural, subarachnoidal, and parenchymatose. We will talk about the differences. Yeah. So please remember the epidural bleeding, the lentiform shape, and the source, the middle meningeal artery. Okay, now we move to the other parts. So we can see here the middle meningeal and inferior alveolar, and then we get from the mandibular part into the pterygoid part. You can see here the muscles. This is the pterygoid, lateral pterygoid muscle, the inferior head. And we can see the close relationship to the mandibular nerve, and the artery runs laterally to mandibular nerve. Yeah? And it has to supply the muscles there. So it supplies the masseter as the masseteric artery. The masseteric artery has to leave through the notch. Yeah, we know that the mandible has got a condylar and coronoid processes. Yeah, coronoid and condylar. And between, the masseteric artery gets out from the pterygopalatine fossa. So it is not drawn here. Then temporalis muscle. Temporalis muscle is supplied by two deep temporal arteries. So we have here the posterior and the anterior deep temporal artery. So then we know that we have 4 temporal arteries. We have the superficial temporal. We have the middle one, which is here, visible, the middle temporal, and then 2 deep, posterior and anterior deep temporal arteries. These deep temporal arteries also give the smaller pterygoid branches for medial and lateral pterygoid muscle. And then we have the buccal artery. The buccal artery, together with the buccal nerve, yeah, they run here and they supplies the buccinator muscle. Yes. The buccal nerve is sensory nerve for the face, as we know, yeah, because the buccinator muscle is supplied by buccal branches of facial nerve, as for the motor innervation. So the buccal nerve is sensory, and buccal artery is supplying the face here. Okay, that's all for this part, for the pterygoid part. And now we enter the pterygopalatine fossa. So we have the pterygopalatine part. And here, all the branches you already know from the skull. So that's just a repetition, and I'll go quite quickly through that. Only if you have questions you ask, yeah? So first branches go and supply the posterior upper teeth. So you have them here, and that's the posterior superior alveolar arteries, which go through the openings in the maxillar tuberosity, which we call alveolar foramina. Yeah, and they of course supply the posterior teeth, that in the molars and some of the premolars, usually the molars only, and they supply not only the teeth but also the alveoli and the gum. Yeah, so all of these. Then we have terminal branch, a continuation, which we call the infraorbital artery. And you know that the infraorbital artery then finally appears here, yeah, in the infraorbital foramen, just below your pupil. And it runs in the floor, in a groove, yeah. So it runs in a groove, and then it runs in a canal. So we have the groove, the sulcus, and then the canal. And in the groove, it gives the middle superior alveolar artery, and in the canal, it gives the anterior superior alveolar artery, yeah, supplying the middle and the anterior teeth. So we have 3 arteries, and we will have 3 nerves supplying the upper teeth. Okay, then we have the descending palatine artery. The descending palatine artery goes down and descending, yeah, sorry, is here, and I have drawn the superior alveolar, sorry, wrongly. This was the posterior superior alveolar for the posterior teeth, and this one, as it's only a scheme, this is the descending palatine. The descending palatine supplies the hard and soft palate. The hard palate by major palatine or greater palatine, and by lesser palatine it supplies the soft palate. Yeah, so that's the descending palatine artery giving the greater and the lesser palatine artery. Then we have the sphenopalatine. Sphenopalatine goes into the nasal cavity via the sphenopalatine foramen. So it's this one. Yeah, and it then divides into septal branches, posterior septal branches, and you know that the anterior septal branches are branches from the ethmoidal artery, and the posterior lateral nasal branches for the lateral wall. One of the branches descends as far as the incisive foramen and supplies the hard palate as the nasopalatine artery. This all you know from the nasal cavity already. And then the really last one is the artery of pterygoid canal. Artery of pterygoid canal is here and goes back dorsal into the nasopharynx. And it gives a pharyngeal branch into palato-vaginal canal. So these 2 branches, the pterygoid canal artery and pharyngeal branch of it, they supply the nasopharynx. So you can see that here we have the branches of the maxillary artery, but all of These should be well known to you. So the branches of the maxillary artery are important for maxillofacial surgery. It is not easy to reach them. And the most important of them is the sphenopalatine artery. As we know, the bleeding from the sphenopalatine artery can appear in hypertension and can cause the epistaxis, so bleeding from the nose. And don't forget about the Kisselbach's spot, which is the area where arterioles of 4 arteries meet here on the septum at the level of the inferior nasal concha. Yeah, if we have a severe bleeding from the sphenopalatine artery, we have either to embolize it, so we go through the radial artery, yeah, and then to aortic arch and up to carotid artery, external carotid artery, maxillary and sphenopalatine, and we put there small plastic structures which embolize it and stops the bleeding. Or we can cause catheterization that through the nose we go here, and via the electric catheter we just burn it, yes, to stop the bleeding. Okay, questions? If there are no questions, we can go on and let's talk about the internal carotid artery. As we said, the internal carotid artery supplies the internal contents of the skull, that means the brain and the eye and the orbit. It supplies majority of the brain, so it brings, one artery brings 40% of the blood. And you can see that it is not direct. As it enters the skull here, as through the carotid canal inside the petrous part of the temporal bone, it gets really curved. Yeah. So as you see, it is curved ventrally and a bit medially, then it goes up, and then it goes again dorsally and curves. So you can really play such a nice game with your hands to see how complicated it is. It is important for surgery and especially for neuroradiology, as you can see here. And based on this curved and sigmoid shape, it has been divided into 7 parts. Yeah, into 7 parts. And you can see that this first part, which looks as a letter C a bit, it's called siphon. In Latin, it's sipho. In English, it's siphon. Yeah, and it means such a tube which is curved. And finally, it supplies the brain. It supplies the brain as a circle, which we call a villus arterial cerebral circle. So now let's go to see this part in detail. So first part is the cervical part. For us important, no branches, and it's dorsolaterally. Yeah, and at the beginning we have this sinus, which is the baroreceptor. Second is inside the bone, yeah, within carotid canal. So we call it petrous part. This is the first band. And the second band here is inside the foramen lacerum. That's why we call it pars lacera. Yeah, it's inside the sphenopetrous cartilage, the synchondrosis. Then it goes up and it gets into cavernous sinus. Yeah, cavernous sinus, we know, is a venous sinus next to or on the lateral sides of the sella turcica, turkey saddle with the hypophysis. So if my head is turkey saddle, the artery goes here up. Yeah. Then it gets close to clinoid process. The anterior clinoid process, you may know, is a part of the lesser wing. So we have very short clinoid part. And we have this ophthalmic part, as it gives the ophthalmic artery into the optic canal. And then finally, it branches into 2 terminal branches, anterior middle cerebral artery. But before, it gives some branches already for the brain. And this is intradurally. Yeah, it's inside the dural space. So we call it communicating branch, as the large branch will be the posterior communicating. So that is just an overview, and we will go through the detail, don't worry. So we start with the cervical part, C1. Again, no branches, and it gets laterally, dorsally, and then dorsomedially. So it winds from behind around the external carotid artery. It's again within the carotid sheath together with the vagus nerve and internal jugular vein. At its beginning, we said there is the baroreceptor, the carotid sinus, and the space where it is, it originates in carotid triangle, and it's part of the parapharyngeal space. And when it reaches the styloid septum, it gets into the retrostyloid space, yeah, together with the ascending pharyngeal artery. You can palpate it here. You can examine it with the ultrasound, which is done routinely. So here you can see the internal carotid artery, then the siphon, and the final branches for the brain. And I said there are no branches, but you can see here a branch, what it is. This is an example of ascending pharyngeal artery branching aberrantly from internal carotid. Yeah? And the answer why it can happen is that they both run, as I said, in a retrostyloid space. Yeah? So the pharyngeal ascending artery can be branched not only from the external carotid, but its origin can be shifted up. Then it's branched from the internal carotid inside the retrostyloid space. This is very rare, yeah, but it can be anatomically explained. So what I can see here is a ultrasound examination. Yeah, on the right, this is caudally and this is cranially. So we can see common carotid artery bifurcating into external carotid, and this is the enlarged sinus. So this is internal carotid. This is internal jugular vein. Yeah. So this is a healthy patient. What happened here? Here you can see a stenosis. Yeah, this is the wall, or I can draw it. This is the wall. And this is already an atherosclerotic plaque. And the more blue, it means the quicker current. That means the blood here gets quicker through this canyon, through this narrowed place. Yeah, and so this is a stenosis. Here we can see stenosis just close to the bifurcation. And of course, if we do not use the Doppler, you can see the stenosis here as well. Yeah, and the stenosis can be very, very, very grave, very critical for the patient. So that's for the first one. If you have there such a stenosis, you can apply end arterectomy. End arterectomy means you open the artery, you take the plaque away, and you close it again. Yeah, you can operate only the first segment. You cannot operate the second and third segment as they are inside the bone, so you cannot get to that. So the second segment inside the carotid canal, so this is the external aperture and internal aperture, so the petrous part, there's are only small branch, caroticotympanic arteries. They are not clinically very important. They supply the tympanic cavity as the fifth arterial source. Yeah. Then it gets into the cartilage. So we have the pars lacera inside the cartilage, and then it gets up into cavernous sinus. And here it's getting interesting. Yeah? In cavernous sinus, you can see how the artery runs close to this big trigeminal nerve and its ganglion. And above the third, fourth, and sixth cranial nerves, which all enter the superior orbital fissure and supply the muscles of the eyeball. So you can see how the artery curves around, and it's close to all these. Yeah? Then it comes to the clinoid process, anterior clinoid process. Then it gets above and gives the ophthalmic artery, and then the posterior communicating artery, and finally it bifurcates into anterior and middle cerebral arteries. So this curved part is the cavernous part. Yeah? It gives some branches here. Even these names which are not underlined are not important for you. They can be very important in clinics, in neuroradiology. Yeah? So if you will be neurologist, neurosurgeon, or neuroradiologist, you have to learn these terms as well. For us, it's important, of course, it supplies the ganglion by the trigeminal ganglionar branches, but it gives inferior branch to hypophysis, yeah, to pituitary gland. We will talk about the pituitary gland in the brain then, and it will be important for us to know that we have two arteries, yeah, for hypophysis. So first branch is from C4 segment. Here we can see the real specimen. And here are the relationship of the carotid, of the cavernous sinus to internal carotid artery. So this is lateral view, and so in a sagittal plane, and this is frontal view. And in frontal view, you can see that the carotid artery is medially, and it's close to abducent nerve. All the other nerves, so the oculomotor, trochlear, ophthalmic and maxillary are in the lateral wall. Abducent nerve is medially close to the artery. That's important for clinics. So you can see again the SIFO here. So we are now in this area. And then we can see the ophthalmic artery here branching. So for the clinoid segment, when I come back here, for the clinoid segment, nothing interesting. The artery can be, of course, a bit narrowed by enlarged anterior clinoid process. And then the ophthalmic part. Ophthalmic part here gives some smaller branches, but what is important, ophthalmic artery on the right angle. Yeah, on the right angle ventrally, ophthalmic artery. And then finally, we come to the C7. But before, we have to talk about the ophthalmic artery itself. Why it's in right angle? We want the blood to come to the eye very slowly, not to destroy the retina. The retina is very fine structure. We will talk about it later. But you now remember when the blood wave during the pulse go through, yeah, then the opening for the ophthalmic artery is closed. So in systole it's closed, and in diastole it's opened. So the blood flows there in slow pulses, and then it gets slower and supplies the eyeball without the pulse. Yeah? It goes together with the optic nerve. And in clinics, it's important that the retinal vessels, the arterioles, the branches of the ophthalmic artery, they suffer from hypertension and diabetes, and then you may remember that blindness is often one of the complications of diabetes. Yeah, but we will talk about this later in the eye. So, which branches of the ophthalmic artery you should know? You can see that there are many branches. And first, we see how it's arranged. So this is a view of the internal skull base without the brain. This is the tentorial notch for the brainstem, infundibulum of the hypophysis of the pituitary gland. This is the carotid artery, optic nerve. This is oculomotor nerve, and the ophthalmic artery is lying below the nerve. Yeah? This is the brain from below, so we can nicely see here, that's the basilar artery, trigeminal nerve, and the optic chiasm, and the carotid artery, internal carotid artery. So this is cut from here, yeah? And the ophthalmic artery is hidden here below the nerve. So we can see the ophthalmic artery and the optic nerve. So this is the origin of the optic canal, anterior clinoid process, and superior ophthalmic fissure, yeah, with the vein. So we now go here. So you can see the nerve and below the artery here, and now the branches. So let's talk about the branches. The most important for vision is the central retinal artery. Yeah? So the central retinal artery is the artery which enters the nerve. It is not visible in this figure, but it enters the nerve. Yeah? It gets into the optic nerve inside, and the nerves conveys it into the eye and into the retina. Yeah? And it supplies the majority of retina, but not rods and cones. Okay, then we have other branches. Lacrimal. Lacrimal is cut here and visible here as it supplies the lacrimal gland. So it runs laterally. Yeah, the lacrimal artery runs here laterally, supplies the lacrimal gland. Supraorbital is not new for you. Supraorbital is this one. Yeah, supraorbital. And you may remember here above the pupil we have two openings, either foramina or notches, frontal and supraorbital. Yeah, so the artery together with the nerve comes here and supplies the forehead. So that's the supraorbital. Anterior ethmoidal. Anterior ethmoidal is here and continues here. And you may remember that it goes through this orbitocranial canal to cribriform plate, where it gives the anterior meningeal artery. And it gets into nasal cavity to give anterior septal branches for septum, anterior lateral nasal branches for the lateral wall, the anterior third, and it gives also the external nasal branch for the tip of nose, yeah, for the apex. It gets superficially in the nasal foramen out, yeah, you may remember that. So this is for the apex of the nose. Yeah, so very complicated course of the anterior ethmoidal artery and nerve through the bone. Yeah, to the cribriform plate, then down to nasal cavity and through nasal foramen to the apex of the nose. Of course, we have the posterior ethmoidal, which supplies the ethmoidal cells. And then the final branches. The final branches are called supratrochlear and dorsal nasal artery. These we can find here. Supratrochlear continues here. Yeah, so it goes parallel to supraorbital, but medially. Supratrochlear, it's found above the trochlea, which we can palpate here. And the dorsal nasal supplies the dorsum of the nose. Yeah. So the terminal branches gets to the face, to the nose and to the forehead. And of course, then we have the muscular branches which supply the muscles. And then we do not have it written, the branches which do not supply the orbit, but which supply the eyeball itself. And these branches should be added. And these branches are called Arteriae ciliares, posteriores, longae, and breves. So in English, short and long, posterior ciliary arteries. Short and long posterior ciliary arteries. We can see them here. Sorry. All these tiny ones, which gets into the eyeball here, close to the optic nerve, and they supply the rods and cones and the other parts of the eyeball, yeah, the choroid and so on. We will talk about that. They are called long and short posterior ciliary arteries. They are also important for vision. So that's all for the ophthalmic artery. And now back to internal carotid. Now the internal carotid comes to its end. We can see again the ophthalmic, which is here. And then finally, the last segment is called the communicating segment. Why it's called communicating segment? We have here two terminal branches, anterior and middle cerebral. Yeah, this is the anterior, left and right. And this is the middle. Yeah, also cut. And the segment which is in between, we can see it here, this segment. This segment gives some branches. One of them is here drawn, and that's the posterior communicating branch. And then this one. Yeah, posterior communicating branch. I will explain the name later. Just now remember that, and it gives the name to the communicating segment. And then we have another branches, the anterior choroid for the choroid plexus of the brain, and superior hypophyseal. Please learn these now just by heart, yeah, and then some smaller branches, as you can see here, for the cortex and for the deeper structures, the perforating branches. So please learn these, and we will come to the letter 2 later in brain, and posterior communicating we will explain. And you can see how here we have a circle formed, yeah, and how this circle, the arteriocerebral circle Willis, is formed. We will just talk about this right now. Before that, don't forget about this figure, the figure of Carotid Sinus with the internal carotid artery. Yeah, this is one of the figures you have to know how to draw it. And now let's look at the circle. Yeah, the circle we can see either here or here. Maybe this is the nicest figure. So how we start? We start here with the internal carotid artery, yeah, the segment C7, which brings 40% of blood. Another 40% by the contralateral one, and then 20% here by basilar. So the internal carotid artery comes here. Here gives the ophthalmic. So this is segment C6. Yeah, ophthalmic comes from C6. And then it gives the middle cerebral. Oh, sorry, just change the color. Middle cerebral laterally. Yeah. And that's here. And the anterior cerebral ventrally. That's here. Then we have here two communicating branches. Anterior communicating branch, which is short, unpaired, half a centimeter, unpaired, yeah, very short one. And then the posterior communicating branch, which is branched from the C7 segment of internal carotid, and it's the longer one. As you can see, the anterior communicating branch connects the left and right internal carotid artery system. And the posterior communicating branch, which is paired, connects the left or right internal carotid system with the system of the basilar artery. Where the basilar artery comes from? Vertebral. And the vertebral comes from subclavian. Yeah? And we have already talked about the subclavian artery before a bit. So we know that the subclavian gives vertebral, and the vertebral, we will talk about the vertebral in a minute in detail, comes here into the brain. You can see the vertebral here. Comes here into the skull via foramen magnum, then connects joins, merge, the left and right merges into basilar. And then the basilar finally divides into posterior cerebral, supplying the occipital lobe. So you can see the posterior cerebral here. Now you have the circle here. Yeah? The basilar artery giving the posterior cerebral, internal carotid artery giving the anterior and middle cerebral, and in between 3 communicating branches, unpaired anterior and paired posterior. Why we have the circle here? So then the blood, when it comes in pulses, the brain does not contain connective tissue much. Yeah, the brain tissue, no, only in meninges, only in vessels, and the brain itself, it's like a jelly. Yeah, if you take a syringe with water and you start to spray water on the brain or on a jelly, what happens? The jelly just blows out. Yeah. If you would tap on the brain all the time like this, what will happen with the jelly? Try to tap on the jelly, then the jelly also gets broken. That's why when the blood comes here, it starts to flow slowly, like in a pond. Yeah. So there is no pulse in the arteries. There is a permanent supply of oxygen. Yeah? In the pulse, it's like giving oxygen, not giving, giving, not giving. But without the pulse, in this steady, permanent, slow flow, the oxygen is still there. And then, if you close one of the source arteries, then the remaining ones can supply the rest of the brain. Yes. So these are 3 reasons why we have the cerebral circle here. But there are many anatomical variations, and in up to 20% of people, the brain cerebral circle is not complete. So then it can be a cause of the stroke in case that some of the source arteries is blocked. Okay, you have to know how to draw the circle. So please learn all the branches which are here. So we have to talk about the other branches. So you can see that the basilar artery gives branches for the cerebellum, superior cerebellar, and then 2 inferior cerebellars, anterior inferior and posterior inferior cerebellar artery. As you can see, anterior is branched from basilar, posterior is branched from the terminal segment of vertebral. So it supplies the cerebellum, as we can see them here, and the last one here, not visible. It supplies the internal ear. We can see labyrinthine artery. Labyrinthine artery can be branch of anterior inferior cerebellar or direct branch of basilar here, and it supplies inner ear. If we have problems with this artery, yeah, for example stenosis, we can have problems with hearing. And then 2 arteries which supply spinal cord. Anterior spinal. Yeah, as you can see, the anterior spinal originates from these 2 short branches from each vertebra, and posterior spinal, which is not drawn here. Posterior spinal. So then the spine has got 3 arteries, unpaired anterior and paired posterior spinal arteries. So question to this, as I consider this very, very important, and you can be tested on the circle any time. Yeah.
I just had a question about the posterior inferior cerebellar.
Yeah.
The posterior spinal you said was coming from there, right?
Yeah.
Okay, thank you.
So then in patient to examine, we use the angiography or CT angiography. So here you can nicely see all the segments of the internal carotid artery, yeah, how it's curved and branches here. And then let's talk about the vertebral artery. The vertebral artery is branched from subclavian artery. So first, subclavian artery. The subclavian artery is branched on the right side from brachiocephalic trunk, as we have talked about that. On the left side, it's an independent branch. It has got three parts based on the relationship to anterior scalenus muscle. We will talk about that later. And we can see that there are some branches, but the very first one is vertebral. Yeah, so very first one is vertebral. So let's talk about the vertebral artery. The vertebral artery ascends along the whole cervical vertebral column. We can distinguish four parts, yeah, which we also give them abbreviations: V1, V2, V3, and intracranial V4. So the V1 is called prevertebral part, is here, and there is nothing interesting. No branch, it just approaches the vertebral column, and when it gets into the transverse foramen of C6, C7 is free of artery, there's only the vein, vertebral vein, but the artery is usually from the level C6. We call it cervical or transverse part. So the cervical or transverse part is the part up here. Yeah. So in here, the artery is hidden inside the transverse foramina, but still it can be examined by ultrasound. It gives some branches, muscular branches for the deep muscles of the neck, longus colli, longus capitis, and also for the deep back muscles in this area. And spinal branches for the spinal cord. At each level, through the intervertebral foramen, there's a thin spinal branch, which then comes and anastomoses with the anterior and posterior spinal branches, arteries we have talked about before. Then it comes to atlas. As you can see, it's making such a curve around the atlas, and it's lying on the posterior Atlantic arch. So we have Atlantic part, which runs through C1, and from that it has to pierce the posterior posterior atlanto-occipital membrane and gets in. Yeah. So here it's important. It's lying on the posterior arch, and then it's get inside the skull. So we call it intracranial, and the intracranial one gives some branches, gives two short innominate source arteries for the anterior spinal artery, so we can, as we saw before, and it gives the inferior posterior cerebral artery, inferior posterior cerebellar artery, giving the posterior spinal artery. And it supplies the meninges as well, so there's some smaller meningeal branches. So now let's look at the figures. So what we can see here is the last segment, the intracranial segment, giving the two innominate branches to form the anterior spinal one, and the posterior is missing in this figure. Well, if you look here, yeah.
Is there like a relevance, like for example, aneurysm? Like, is there any artery that would be like more dangerous for the patient?
Not from aneurysms. The aneurysms can appear, as I show you a bit later, on all the arteries of the Willis circle. Yeah, I will talk about the clinical relevance in a minute if you wait.
Okay, sorry, thank you.
And we can talk about this right here. What we can see here on the left, and I may label it as well. So this is the segment V2. Yeah. Still, segment V2 is as far as here. This is again digital subtraction angiography. We can see here atlanto-occipital joint. And the skull. So the artery has to, here is C2, so it, and this is okay, C1, and here is C2. So it has to get laterally through the transverse foramen of atlas, then it's in a groove on the posterior arch of atlas, and it gets inside the skull. So then we have the Atlantic part. This is the Atlantic part. Yeah, so V3. And then V4, which is the intracranial part. And this is already the basilar artery. So you can see the complicated course. If you rotate the head to the side and turn it, flip it dorsally, then you compress one of the arteries. Yeah. So in case you can see this, there's a stenosis, and you rotate and compress this, what will then happen? Nearly no blood comes to a basilar artery, and the basilar artery supplies the brain stem, and the brain stem contains the articular formation, which is important for your consciousness, heartbeat, breathing, and so on. So in case no blood comes here, which we call vertebral basilar insufficiency, vertebral basilar insufficiency. So what then happens? You are just losing your consciousness. Yeah, you can be dead, but there are these communications from the internal carotid artery, the posterior communicating artery, which will save your life. Yeah, so this is really clinically very relevant. And again, here you can see how it's complicated occurs. Yeah. And this helps us to distinguish the vertebral artery from the internal carotid artery, yeah, which are the other ones in angiography. That's why we should know about both complicated courses. Yeah, and again, you can see how it's complicated. And then when we come to basilar artery, we have already talked about the branches supplying the cerebellum. So the inferior anterior, giving also the labyrinthine artery for inner ear, and superior cerebellar, supplying the superior aspect of cerebellum. And finally, it gives the posterior cerebrum. So now we know all the branches. And as we said, if you really rotate the head, and sometimes it's called beauty parlor syndrome, or in Czech, it's called a syndrome of viewing cathedrals. So if you come to the Prague Castle, to the third courtyard, you can see nicely the cathedral. Or if you are at your hairdresser and you put the head in these, so you flip it dorsally and you turn, you can block one of the arteries, and in case of stenosis, you can cause unconsciousness. Yeah. Of course, it could not be only unconsciousness. It can start as a vertigo. It can start as a doubled vision or blurred vision, but it can terminate as a stroke. Yeah. So this is very important thing. And the other thing which is connected to vertebral artery is the subclavian steal syndrome. So what you can see here, the subclavian artery, the left subclavian artery in this case here is blocked by atherosclerosis. It seems that it's blocked by atherosclerosis. So how then the blood flows into the upper limb? It flows through the internal carotid artery to the brain, and then back via the vertebral artery, and then to the upper limb. Yeah. So if you start to use the upper limb very much, then the blood which should go into the brain is diverted to the upper limb, and then you can again have problems with your consciousness. Yeah, you can have a vertigo, syncope, or you can feel pain in your upper limbs as there is not enough oxygen. So subclavian still syndrome is another clinically relevant situation based on knowledge of anatomy. So what about the aneurysms? Now, aneurysms can appear at any of the branches of the Willis circle, but most commonly they are here on anterior communicating artery. And what is again clinically interesting is that in this area we have the optic chiasm. Yeah, here we have the optic chiasm. Optic chiasm is the accusation of the optic nerves. So if this aneurysm compresses the optic nerve, you can have problems with the vision in some of the eyes. Yeah, you can have a limitation of your visual field. So before the aneurysm bursts and causes death, you can reveal it in the patient. Yeah. But you can see it can be located in some other areas, and it can really rupture or burst in any time. Yeah? So sometimes it's accidental finding, and then you are happy you have found it. But there can be young sportsmen just running and then falling dead because the aneurysm bursted and caused subarachnoidal bleeding. But most commonly it is located in the anterior communicating artery. Okay, let's go back to subclavian artery, which is the last topic of today. So we know that the subclavian artery forms a groove on the tip of the lung. We know that it leaves the thorax in the thoracic inlet. We know it lies on the first rib, forming a groove here. So we can have something which is called thoracic outlet syndrome. It can be compressed in the thoracic outlet by a tumor of the apex of the lung, for example. Yeah, and it can suffer here from the subclavian syndrome we have already talked about. So that's the important topography. And now we can see here the artery behind the vein, then running inside the scalenic fissure, so behind the anterior scalene and in front of the middle scalene, and giving the branches. Yeah, you can see the vertebral artery here, but we have here some more branches. So based on the relationship between the artery and scalene muscles, we can distinguish three parts. The middle part we call interscalenic, as it's between anterior and middle scalene muscle. The third part we call extrascalenic, as we can see it outside. Yeah, this is this part, so you saw it emerging from the scalene muscles. And the first part is medially to scalene muscle. The name is not nice, intrascalenic, yeah, which should mean it is inside the scalenic muscles, but it's inside scalenovertebral triangle. Yeah, it's inside scalenovertebral triangle. So we can even maybe write it here. This part is inside scalenovertebral triangle. That's why we call it intrascalenic part. Yeah. Now let's talk about the branches. So the first branch is the vertebral artery. Yeah, it goes up. And then we have the thyrocervical trunk. Thyrocervical trunk gives thyroid artery, inferior thyroid, and cervical, ascending cervical artery. And then it gives another two important arteries, suprascapular, well known from the upper limb, and transverse cervical. Yeah? I'll come to these again in detail. Then we have internal thoracic. And we already know the superior epigastric supplying rectus abdominis muscle. And it supplies the anterior intercostal spaces. The second part, interscalenex, gives costocervical trunk. Costocervical means it supplies intercostal spaces and it supplies neck, deep cervical. And then the extrascalenex, usually no branches. If there are some branches, it's usually the deep branch. This one is shifted here. Yeah? The deep branch of the transverse cervical artery is not here, but it's here. Like a variation. Yeah? Let's talk about this in detail. So the first intrascalenex part, vertebral artery, solved. Now internal thoracic and then thyrocervical trunk. So internal thoracic artery runs caudally, and when it reaches the diaphragm, it continues as superior epigastric and forms anastomosis with inferior epigastric inside the rectus abdominis muscle. On the way, it gives anterior intercostal branch into every intercostal space, the first sixth. When it comes to the diaphragm, it gives this branch which follows the diaphragm. It's called musculophrenic branch. Yeah, musculophrenic. And this musculophrenic branch supplies the remaining three anterior intercostal spaces, so the 7th to 9th. What about the 10th and 11th intercostal space? It is, of course, not supplied by the internal thoracic artery, as these spaces do not exist ventrally. Yeah? It do not exist ventrally. It exists only dorsally, as these two last ribs are free ribs. So that's for intercostal spaces. Now there are some other branches you should know. Pericardiophrenik. Pericardiophrenik artery is an artery which descends this way on the pericardium of the heart, supplies the pericardium and then the diaphragm, and it descends together with the phrenic nerve. Yeah? So pericardiophrenik artery together with the phrenic nerve within the inferior middle mediastinum to supply the pericardium. And then you can see some smaller branches, yeah? Like mediastinal and thymic branches, yeah, for the rest of the thymus and for the connective tissue and adipose tissue. Sternal branches for the bone. And then some of the intercostal anterior branches, they give perforating branches and medial mammary branches to supply the mammary gland and the breast. Yeah. So these are the branches of the internal thoracic artery. As you can see, the artery runs here, and it can be used if you cut all these branches. It can be used as a bypass for the heart. You open the sternum by sternotomy, yeah, in the midline. You cut all the branches and you free the artery, and then you use the artery as a bypass. Yeah? So you take the end and you suture it behind a narrowed part of the coronary artery, behind the blockage, and then the blood to the heart goes this way. Yeah? This is the most commonly used bypass. The other kind of bypasses we can use are the grafts, which are connected directly to aorta, and they are usually taken from great saphenous vein. So the internal thoracic artery used to be called internal mammary artery, as it also supplies, as I said, by the perforating branches, the mammary gland. But now we call it, already for some 85 years, internal thoracic artery, but still in clinics, they use the term internal mammary artery. So if you see the clinical abbreviation left internal mammary, right internal mammary, lima, you will know that this bypass is based on the internal thoracic artery. This artery is elastic, so it does not suffer so much from atherosclerosis, which is fine. So then here you can see such an artery here with shown with the angiography, used for the heart bypass. Okay, so that's for the internal thoracic, and now thyrocervical trunk. Thyrocervical trunk, and I come back here. Thyrocervical trunk here gives the inferior thyroid, ascending cervical, transverse cervical, and suprascapular. These 4 arteries. So we start with the inferior thyroid. The inferior thyroid in this area, I may label it. So we can see it runs this way and here. Supplies not only the thyroid gland, but also the inferior part of the larynx, below the vocal cords. But it also supplies esophagus, pharynx, and trachea. But what is very, very important, it is crossed by recurrent laryngeal nerve. And in thyroidectomy, when you have to remove the thyroid gland, you have to clip the artery here, and you can see the nerve. The nerve is this one. And if you harm the nerve, you can cause, if you harm it unilaterally, problem with the voice, and bilaterally, then the patient even suffocates. So please pay attention to this. Anterior ascending cervical artery is a branch which comes either from the trunk or from inferior thyroid up, and it's important, it runs together with phrenic nerve. So the phrenic nerve you can see here, this is the phrenic nerve. So it runs together with the phrenic nerve down. And don't forget that inside thorax, the phrenic nerve runs together with the pericardiaco-phrenic artery from internal thoracic. But here, on the anterior scalene muscle, it runs together with the ascending cervical artery. The ascending cervical artery supplies the muscles, the scalene muscles, the deep muscles of the neck, but also it gives spinal branches to the spinal cord. So that's the first, clinically more relevant. And then another 2 branches. One is suprascapular. Suprascapular branch, suprascapular artery, together with the suprascapular nerve, you know it, and it runs above the suprascapular ligament or the superior transverse ligament of scapula, so above the scapular notch, and then inside the spinoglenoidal notch. This you know, and it supplies the supraspinous, infraspinous muscles. So there's nothing special about this artery. And then what is really complicated is this artery, transverse cervical. The transverse cervical artery in a textbook pattern is branch from the trunk and gives superficial branch and deep branch. The superficial branch supplies the neck here superficially in the omotrapezoid triangle. The deep branch descends to the medial margin of scapula and runs together with the dorsal scapular nerve. You may know that dorsal scapular nerve supplies rhomboid muscles and levator scapulae muscle. So this artery also supplies these muscles. Yeah, so it's a neurovascular bundle. So the D branch is the same as the dorsal scapular artery. But as you can see, it's branch of this area only in 1/3 of cases. Otherwise, it's a branch from the extrascalenic part. So it can be different here. In every patient, a bit different. Yeah. In some patient, you have the cervical transverse artery with 2 branches, superficial and deep. In some patients, you have only the superficial branch here present. So sometimes it's called superficial cervical artery in some books. And the deep branch, then called the dorsal scapular artery, is branched off from the extrascalenic part. Yeah, so this is quite variable. So I'll come to this, and again we can see the suprascapular artery here. Yeah, here running across the superior transverse scapular ligament, and here through spinophlenoid notch. And then the oh, I'm sorry, here's a mistake. This is the cervical transverse artery, arteria transversa coli, yeah, cervical transverse, gives superficial branch, and the deep, which is called the dorsal scapular. And dorsal scapular runs here to supply the rhomboid and the levator. Yes? Okay. Now the second segment, the interscalenex segment. The interscalenic gives 2 branches, deep cervical and supreme intercostal. Yeah, deep cervical and supreme intercostal. Okay, deep cervical goes deep inside the neck muscles, so longus colli scaleni, and it also supplies the deep back muscles. So it runs within the omotrapezoid triangle. And the supreme intercostal descends here to supply the first and second intercostal space from dorsally. So it gives first and second intercostal posterior artery. Why not the third? The third is supplied from aorta. Yeah, here branches are branches from aorta. So the aorta gives the third one. And of course, there are connections with the internal thoracic. Yeah, this one is internal thoracic artery. So here we have the connections within the intercostal spaces. So this is not much clinically relevant. It's hidden by the muscles, and you just should know the name of the arteries and what they supply shortly. And that's it for today. Yeah, I'll just go back to the external extrascalenic part. As we can see, for example, here, the extrascalenic part. And sometimes you find in books that from the extrascalenic part, the deep branch of the transverse cervical, or as we call it also, the dorsal scapular artery, is drawn. Yeah, so it can be either branch from the transverse cervical, yeah, as it's here, or it can be here a branch from the extrascalenic part. It depends. Okay, so that's all for today. As for the anatomy, I have some last clinical notes, if you do not mind. And we still have to talk about atherosclerosis. Yeah. So Atherosclerosis is a very severe condition, and it's problems that we have the deposits of lipids, polysaccharides, thrombocytes, and cholesterol subintimally. So below tunica intima, you can see here how the cells, they start to accumulate these polysaccharides and lipids, and finally they are calcified, so they form such plaques. Yeah, so fibrotization and calcification. Then it's so pouched, and it can cause thrombotization and then closure and hypoxia, ischemia, and necrosis. So it can be, it's really clinically silent until a stenosis, thrombosis, aneurysma, or emboli occurs. That's very important. But if you have the insufficient supply of the tissues, you can have claudications. What means claudication? That means a pain after some work. Yeah. So typical claudications are when you have atherosclerosis in lower limbs and you walk for a longer time, you can feel pain in your lower limb muscles. Such claudication can be in the heart. If your heart works more, then you can feel pain in the heart, which is called angina pectoris in Latin. Yeah? And if there's a sudden closure, it can cause stroke in brain or a heart attack. So what are the risk factors? Of course, obesity and lack of movement, smoking, diabetes, hypertension, and too much of the LDL kind of lipids. The diagnosis is easy: ultrasound, angiography. Yeah. So what then you can see on histology? Yeah, quite nice media, but then here the atheroma with these crystals of calcium, and here erythrocytes, and not a nice intima, so thrombus on the surface. Nice, healthy coronary artery. Yeah, this is epicardial fat. And then quite nice artery on the section, and artery filled with atheroma and residual lumen in here. Yeah. This is an open artery. You can see here the side branches, and these are atherosclerotic plaques in our vessels. And of course, the thrombosis then causes infarction. And you can see this is the vessel with atherosclerotic plaques, and there's a thrombosis. So this is the infarction of the heart. Yeah, here you can see how the heart is not nicely colored. Yeah, it's dark red. And there's thrombosis in the interior interventricular branch. And on the section of the heart, you do not see this nice red-brown muscle, but the white scar after infarction. And even the papillary muscle is not nice. Yeah, and we have already saw these figures. And on CTs and MRIs, this is a healthy aortic arch with the branches. And I'll come to some problems like aneurysm on the internal carotid artery on the neck. Yeah, so there is not a straight course, but you can see how it's curved and enlarged. And what we can see here, this is a 3D reconstruction of the villus of circle. So you can see that there are all the connections, but moreover we have here something at it. So every patient has got some anatomical variation. Even this variation does not make a problem. But what you can see here is a villus circle, yeah, with the vertebral artery, the basilar artery, the posterior cerebral, the communicating branches, anterior cerebral and middle cerebral, and the big aneurysm. Yeah, how we treat this aneurysm? Either we put a clip here, yeah, from outside you put a clip, or another possibility is that you come You come by the radial artery with the wire. You put here a coil. The coil here closes the space, stops the blood flow, and starts a thrombus and fibrotization, and finally it's closed. Yeah? So it's called coiling. Yes.
Where do you open, like on the skull, to attack this area? Like, because this is in the middle of the skull, right?
Yeah, it's in the middle. It's basally. So if you would like to come here, you have to go from different areas depending where it is to come with the clip.
Okay,
it depends on the position.
But usually, like lateral, like, as you show in your head, is it like this line, like this lateral line?
Yeah, you try to go below the brain. Yeah.
Oh, okay.
So somewhere in these areas. Yeah.
Yes, thank you.
And then, of course, the aneurysma can be also very small. Yeah, as you can see here, when I come back to this one, this is the internal carotid artery, yeah, giving the branches. So we have the anterior cerebral here, and the branches from the middle cerebral here dorsally. So this is the normal one. We will talk about this later in brain. But you can see that this small, this is the middle cerebral and the posterior, and the anterior, and this small is also an aneurysm which can cause fatal bleeding. Okay, I think that's all. Of course, here you can see a patient with occlusion of the internal carotid artery on the right side and stenosis on the left side. So you can see that here we do not have 40%, here we have 20%. So this patient has got about 60% less blood coming to the brain, which can then cause easily a stroke. So last questions.
I have a question.
Yeah.
From a histological point of view, how can we? I mean, we can differentiate between elastic and muscular, and big and small.
Very easily. I don't have the figures here, but in elastic artery, you nicely see the elastic membranes, which are like wavy. Yeah.
Yeah, but I mean, like to bring it to a macroscopic point of view. Like
yeah, you cannot.
No,
you cannot distinguish macroscopically. You have to know that elastic are aorta, and then the origins of the large vessels. That means subclavian, carotid, external iliac, and that's it. Then popliteal, yeah, as you bend the knee, and internal thoracic. These are elastic.
Okay, thank you.
Yeah, you're welcome. Other questions? Okay, if there are no other questions, thank you very much for attention, and we hear each other on Wednesday.